Thank you very much. It's such a pleasure to be here. It's very meaningful to me to be here, to be part of this 5th annual symposium. I'd like to thank Dr. Yossi Levy-Beltz and Sami Hamdan for inviting me to participate. It's such an opportunity for me to reconnect with old friends and colleagues, as well as to make new friends and colleagues, and to share my work with you today. So I'm going to share with you the trajectory of my involvement in suicide prevention, research, and as a clinician. I'm a scientist practitioner, so for more years than I care to admit to you, I've been involved in doing clinical research at the Center for Suicide Research at Columbia University and the New York State Psychiatric Institute, where I met Dr. Salzman when he came through. And it's been very fortunate for me. And I started to gear towards studying borderline personality disorder with my main colleague and mentor, Dr. Barbara Stanley. I want to share with you current research that we're doing in the lab, but I also want to really connect it to on-the-ground clinical practice. I'm here to bring you the picture from the United States as well. In the United States, suicide is definitely reaching epidemic proportions, and this is just how a little taste of what we see in the media in the United States. I don't really need to tell you about the problem. That's why we're all here. I was very encouraged to see that the suicide rate is going down here in Israel, and especially from what I could glean from this morning's presentations, we really need to learn more from you guys. You're doing such great work here, and I'd like to be able to read your work in English when it gets published, because ours is going up. Look at in the United States, a 50% increase in death by suicide in the last 15 years. And also what's disturbing is the people who are dying by suicide, not just in the past elderly white males, at least in the United States, but how many youth, how quickly the suicide rate has gone up in youth, and I think that's the same here as well, age 15 to 24. And military populations, both here and in the United States, and new immigrants, particularly here, are more vulnerable populations. So even though we're doing so much research and we're developing evidence-based interventions like DBT, which I am a practitioner of, we're still seeing so much increase in suicide. So it's a little disturbing, and we need to understand more. And so we need to keep having a very comprehensive approach to suicide prevention, and these are different points of intervention that we look at for trying to understand, identify people at risk, and then doing good risk assessment to really be able to highlight who are the people who need immediate care, and then what? What do we do with them once we identify them and know that they need care? So we need to have interventions, and we need to have evidence-based interventions, not just treatment as usual. Treatment as usual doesn't really target suicidal behavior. I'm going to say more about that. I also want to say that my history of being a clinical psychologist is that I was originally trained in psychodynamic psychotherapy, and I learned how to treat borderline personality disorder with Dr. Otto Kernberg back in the days. And then I came to work at the Suicide Prevention Research Center and realized that my psychodynamic training really did not prepare me for treating people with borderline personality disorder, not the suicidal behaviors. I was at a loss. So that's when I trained in dialectical behavior therapy. I trained in that in order to do research, not actually to be a clinician. That was my first entry, and actually Dr. Yoram Yovel was in that training with me way back when. We go back. We studied with Marshall Linehan, and we came back to Columbia and started doing research, and I started being a research dialectical behavior therapy clinician, and then of course it entered into my private practice and my way of thinking. So part of what I'm going to share with you today also is having to thinking about, as being a clinician or learning how to be a clinician, how to take research, because research is crucial in understanding what's going to work. And I've been doing that for a long time. But then, in the past few years, I have come to learn that people in the field are not learning what I'm learning in the lab. So in the last few years, my efforts have kind of shifted over. I still am doing lab research and clinical research, but I'm very focused on how to translate that research into training people who are on the ground dealing with suicidal individuals. Okay. And in Dr. Zalzman's review of almost 2,000 studies to come up with recommendations for evidence-based suicide prevention strategy. These are the different recommendations that he and his colleagues recommended for really using evidence-based principles to attack the problem. Means restriction. Getting trained and using evidence-based treatments in both medication treatment and psychotherapy treatment, including CBT and DBT. Having the system be more of a follow-up chain of care. So that's very important, and that's something that as an individual clinician we don't always have as much control over as we would like, but systems also have to change in order to, once we identify people who are really at high risk, how to follow them through and put them on a pathway to care and not to just let them fall through the cracks. Continue to do population screening, but we need to combine it with ongoing monitoring and care. I loved what I heard and the bits that I understood from this morning about using new social media and technologies in order to also reach out to the people who might not necessarily show up in our offices. And my take-home message actually from that review was that research must lead to implementation. Oh, and I skipped one, that we do need to keep doing more randomized controlled trials. And up until recently, those did not include people at risk for suicide. I think the thinking was that if we targeted depression and anxiety, and we did clinical trials to see which treatments were effective in reducing depression, we would also be reducing suicidal behavior, but that's not the case. And the latest thinking in the field is to target suicidal behavior directly. And that means we need to develop protocols for including people at risk for suicide in our research. So I already said my talk today is to share with you my transformation from being a research clinician into putting that to use on the ground. So I'm going to share with you some of our research recently from a randomized clinical trial of individuals with borderline personality disorder. We were testing DBT, dialectical behavior therapy, and SSRI medication. We randomized 84 individuals into 2 different treatment groups. But I'm not here to share those results with you today. I'm here to share with you another part of that study that happened before they were even randomized into treatment. And then I'm going to share how those findings, I think, can very much translate into certain take-home principles, like a toolkit for those of you who are working clinically, and I'm assuming that's many of you here, or training to work clinically, that you don't have to be a trained DBT clinician in order to be better at treating suicidal behavior. So evidence-based treatments have certain tools that you can use that I want to share with you. And I'm going to use that with a clinical example to show you. So we recruited 84 people in this study. They all had borderline personality disorder. And so I know that you're going to think that these results are specific to them, and that's true. They are, but I'm also going to share with you the fact that it also can extend to other suicidal people who don't necessarily meet criteria for that disorder. Before they were randomized into treatment, all of them also had recent suicidal or non-suicidal self-injurious behavior. So this was a high-risk group that we were putting into a randomized trial of either psychotherapy or medication. When I first started doing this research, when we first came back from Seattle in our DBT training, and we started a study where we put people randomly into either DBT or supportive therapy, medication, or placebo, and I was one of the research therapists, and I didn't know whether my patient was on medication or not, it terrified me, I have to tell you, because I felt like, how do I know if I have all the tools that I need to help control their suicidality? But this is the kind of work that we need to do in order to really get the findings. We have to take the risk of putting people at risk into these trials. So before, though, these 84 were randomized, we gave them a week of ecological momentary assessment, which I'm going to explain to you what that is, a measure of their suicidal ideation over the course of the week. We wanted to learn about the patterns of suicidal ideation and other factors that might be happening in their lives during a course of a week that might influence their suicidal ideation and behavior. So just to give you a little taste of the sample, 84 individuals with a mean age of 30 years old, mostly female, mostly white, and with high percentages of comorbid major depressive disorder, current substance abuse, and childhood abuse, physical and sexual. And they had moderate to high scores on most of the variables that are the, suspected culprits, the correlates of suicidal behavior, like impulsivity, aggression, hopelessness. They also had significantly high reasons for living as well. And all of them had suicidal ideation recently, and 3/4 of them had a history of a suicide attempt. The mean maximum lethality was not that high, so most of these suicide attempts were not highly medically damaging. And almost all of them had some non-suicidal self-injury or self-harm. So this is the ecological momentary assessment, and I'm taking to heart, using new technology. That's not very new anymore, right? The Palm Pilot. In fact, during the course of the study, we originally developed our software for this instrument, and then they would get lost. We would give them to participants, and we wouldn't get them back, and then they were obsolete, and we couldn't buy new ones. We had to go on eBay to get new ones. Well, we did. We got through it, and oh, okay. Can you hear me better now? And we, each of them took this home for a week, and it was going to prompt them 6 times a day to answer questions. These were the questions. And they were prompted at very random times, so each day it would be at a different time. They were asked, in the past 15 minutes, on a scale of 0 to 4, 0 being very slightly or not at all, 4 extremely, do you have a wish to live, a wish to die, a wish to escape, thoughts about suicide, urges to committing suicide, and now that's not the right language anymore, but this is a few years ago. We don't say commit suicide anymore. Thoughts about hurting self, an urge to hurt yourself, and also, do you feel like you have reasons for living? At the same prompt, they were asked, since the last time you were asked to answer these questions, did any of these life events happen to you? Did you have a disagreement with someone? Were you rejected? Were you complimented or praised? Were you disappointed or felt neglected? Did you experience a loss? Did you receive good news? Did you receive bad news? Were you reminded of something painful from the past? And the final set of questions at each prompt, to what degree did you use any of these coping strategies to deal with these feelings or events? Did I keep myself busy, socialize with others, focus on positive thoughts? Did I do something good for myself, calm myself down, try to find perspective? Did I sit with the feelings until they passed? And then they were asked to rate subjectively whether any of these coping skills that they used, were they effective to help them out. So 84 people completed this. These 4 different patterns. Is there, oh yes, okay, oops, I'm sorry. Okay. So these 4 patterns pretty much were what we saw in the variability of suicidal ideation across a week. So that first pattern, the high variability, that's within a course of a day. You can see it going from almost 0 to 30. That's the range of the measure. The second pattern was more moderate, but still quite variable. And then the 2 others were more stable. Some didn't have much ideation at all, and some had low but stable ideation. This illustration shows two different research participants who had the same score on the scale, the Beck scale for suicidal ideation, which is the most commonly used research measure that we have to measure ideation. And they both had the same score of 13, but look at the difference on the EMA data about how variable the suicidal ideation was. And just in case you think that this is just because they have borderline personality disorder, and it might be that that's the case, I threw in this slide of another study that we did that was not a randomized controlled trial. It was a prospective study looking at suicidal ideation and behavior in 3 different groups. So the blue group, the blue line, indicates people with borderline personality disorder with a history of suicide attempt, and this was the Beck scale of suicidal ideation over the course of a year. Every month they were called and they were rated on the Beck scale, and there was quite a bit of variation across the month. The green line represents people who did not have borderline personality disorder. They had major depressive disorder without borderline, and they still had quite a bit of variation over the course of the year. The red line, the most stable line, people with borderline personality disorder but no history of suicide attempts. So I just want to impress upon you the idea that as a clinician, you're really dealing with fluctuations in suicidal ideation in any of the people that you see that are at risk or have a history of suicide attempt. So just to give you a little more of the data here, let's see if I can point the pointer. Okay, this first chart shows those events that we asked about. Did you get good news, bad news? Did you feel disappointed, rejected? When we looked at them individually, all of the negative life events were associated with a spike in suicidal ideation, but the positive events, like getting a compliment or good news, were not significantly associated. When we put it in a multiple regression model to control for the different events, the only 2 events that were significantly related with a spike in ideation was having a disagreement or feeling neglected. Can people see it okay? Okay. So this next chart shows, okay, and what about those coping strategies, right? They were asked if they used coping strategies, and if their self-report on the far right, they thought that all of their coping strategies were working great for them. But when we actually looked at how it was related to suicidal ideation, and we did it in a multivariate analysis, so we're looking at, I'm having trouble with this column here, only keeping busy was significantly correlated, associated with a decrease in suicidal ideation. Okay. And also, just to throw in depression into this, because depression is the main thing that we think about in terms of risk for suicidal ideation. Actually, the people who reported subjectively lower levels of depression were more reactive to those life events. That could be due to borderline personality disorder, right? Okay, and so after being rejected, people who had lower levels of depression were more likely to have a spike in their ideation than the people who reported higher levels of depression to start with. And that was the same with after a disagreement. So just to summarize what we learned from this is that individuals had very different patterns of suicidal ideation over the week. People who had the same diagnosis, same kind of risk factors for suicide, they had very different patterns of ideation, and the patterns were very variable, really variable, some of them. And that this methodology gave us a new window into understanding the forces that impact on a daily basis on people's level of ideation and risk. Our research supports the relationship between interpersonal sensitivity and reactivity and suicidal ideation in people with borderline personality disorder, and depression is not as big of a factor. And And that distraction is really the best coping skill when you're in a suicidal crisis. When we're teaching coping skills, some of those other skills about sitting with your feelings, trying to have a positive, focus on the positive, cognitive reformulation, that doesn't work when you're at a spike in suicidal ideation. The best skill at that time is keep busy and distract yourself. So this is good clinical information in terms of coaching people about when to use which coping skill, okay? So now I want to switch over into how do we take this information and how does that really impact you on the ground working with suicidal individuals? I think that we have to keep in the forefront of our minds about these fluctuations in suicidal ideation. We can't just ask once about it. We have to be constantly asking about the presence of suicidal ideation and the quality of it. And we need more training and guidance in order to be able to do that, because I don't know about you, but in my training, that really wasn't much part of my training, is to understand these different variabilities in suicidal ideation and how to know that and ask about it all the time. So, and we also want to learn how to identify individual patterns of suicidal ideation in your patients, and your parents too, and to learn how to anticipate and be ready for those spikes. So we want to be ready and to have an idea to make it more predictable. I think that's one of the really scary things about working with suicidal individuals and people with borderline personality disorder in particular, because it seems so unpredictable. It goes up and down and you don't really know. But some of these data show that actually we can start to know certain events spike ideation and certain coping skills work to ride it through. And so that's helpful to us as clinicians and also to teach to our patients so that they can know that for themselves. So we have some of this knowledge, but the knowledge does not always make it to clinical practice. One component of my work these days is working with New York State. There's an initiative in the United States called Zero Suicide. I think Dr. Zaltzman mentioned it earlier. And so our team is working with the New York State Zero Suicide initiative to learn to get these concepts into the clinics. How do we train clinicians to take the knowledge that we know from the lab and learn how to use it with their patients and to fill those gaps in our clinical training? I think this is still happening. Maybe it's not happening here, but standard clinical training for suicide management is to ask somebody who's in front of you whether they have suicidal ideation, although people don't always even do that. And if they say yes, is it passive? Is it active? Do you have any plans attached to the ideation or no? Do you have any intent to act, yes or no? If some of the answers to those questions are yes, then we're in the position of having to do something about it. And I think that's one of the reasons that we don't ask as directly as we need to, is because we're not that confident about what to do about it. I think some of the research this morning showed that as soon as you have a little bit more information about what to do, you're more willing to ask these questions and do the risk assessment. But if you don't know what to do or you feel anxious or legally liable, you might try to avoid it. Well, once you know that somebody's at risk, what are the options? In the past, contracting for safety, right? If somebody can promise that they won't act on these urges until the next visit, okay. Otherwise, do I hospitalize, yes or no? And I was reviewing these slides with my Israeli consultant, who's a postdoc with us, Dr. Liat Itzhaki, who some of you might know. And she told me that as a psychologist here in Israel, she was trained that if somebody answered yes to these questions, she should just refer them to the psychiatrist. Yes, I see nods here, okay. So, what are the limitations of this standard training? We're not given enough guidelines about how to inquire and to do a better history of suicidal ideation and past suicidal behavior. And we're not really trained to understand the fluctuating nature of suicidal ideation and risk and how to anticipate with a particular patient when they might spike in risk and to know what the high-risk periods are. And we don't have that many tools for helping people stay safe outside of the hospital. So that leads to over-reliance on hospitalization. And in the current climate in the United States anyway, it's not always an option. It's much harder to hospitalize a patient. And the other thing is it's not helpful for an individual. If you remember the spikes and how the fluctuation of the ideation, if somebody's at the top of the peak and you decide to hospitalize them, you don't give them the chance to come back down again. And so then you've disrupted their life because of that moment in time and made it much harder for them to reestablish their life. And you're not giving them a way of learning how to manage their urges and to stay safe on their own outside the hospital. And contracting for safety just doesn't work. So, in order to do the zero suicide work in New York State, we reviewed all of the evidence-based treatments that exist for suicide prevention, DBT, cognitive therapy for suicide prevention, safety planning, and they have 10 common factors that can be like a toolkit for clinicians, that you don't have to be a trained DBT or CTSP therapist in order to incorporate some of these into your practice. And it's based directly on the research of the fluctuations in suicidal ideation and risk. So these are the top 10 steps, the common factors for applying best practices into your practice. And I think, Yossi Beltz, you were talking about, the guilt that survivors have. And as clinicians, we are, and you mentioned that, we are also survivors of people in our care who have died by suicide. Hopefully not, but we're at high risk for that. And so for us to know that we're doing what is the state-of-the-art, best practice, evidence-based treatment for the people in our care goes a long way, I think, in mitigating that kind of shame and guilt. People used to ask me, how do you do the work that you do, working with suicidal patients all the time? And I mean, you do have to enjoy it somehow. You have to find challenge and feel like you're helping people. But, other disciplines in medicine deal with high risk, people of high risk of dying all the time. Unfortunately, like oncologists, for example, right? So part of this is the stigma attached to suicide and suicide prevention. Suicide can be prevented most of the time, much more than we think, but we can know that we're doing our best effort, and we can document that we're doing our best effort, and that's what we can do. So I just want to share these 10 steps with you and to share a clinical example in order to illustrate how to apply these steps in clinical care. So you want to explicitly inquire about suicidal ideation, past and present. You want to know about other risk factors for suicide besides the history of suicide attempt, even though we know that past attempt is the most strongest factor for future attempt. Almost 50% of people who die by suicide do it the first time they try. So there's a whole bunch of people out there who are at risk, but they don't have that risk factor to rely on. So we need to be familiar with the other risk factors. We have to learn to make continued focus on safety an explicit goal, and that's one thing I learned from switching to psychodynamic psychotherapy to a more cognitive behavioral approach, is to make suicidal behavior, it's a behavior, and it's a behavioral goal in treatment, and it's something that's constantly monitored across treatment. Developing a collaborative plan like safety planning and means restriction, teaching coping skills, and also, this is another switch that happened for me when I switched from psychodynamic to more cognitive behavioral, is to think outside the box about the frame of treatment. I was trained that treatment happened at this time, in this place, once a week, maybe twice a week, and in between, no contact, and just wait for the person to show up. That does not work in suicide prevention, and I think that that frame needs to be reconsidered. So, increasing contact and flexibility in the treatment frame, knowing how to monitor and know the high periods of risk, and then not being there by yourself. You're not being a lone warrior. You want to include members of the person's support system and your own support system of your peers, your clinicians in your peer group. in order to be on board with you. All of these steps then can be documented very clearly so that you can document everything you've done, all of your clinical thinking and rationale, and you can communicate it to other providers working with the person. All of these 10 steps are also summed up in this model that we created for New York State, which is called the AIM model. So all of those 10 fit into assess, intervene, and monitor. So how does that happen in the clinic? So meet Paul. He's a 32-year-old single male with a college degree. He lives with his roommate and he works as a graphic artist in a small startup company. He has quite a number of strengths. He's a talented artist and he interviews really well and he gets his jobs, but then things get in the way and he loses them. In college, he actually was very close to graduating, and then he just kind of went AWOL. He disappeared for the last 2 weeks of his senior project because he couldn't hand it in. And then he had to take a medical leave. Feelings of shame and difficulty with authority interfere with his success at work. Paul engages in periodic non-suicidal self-injury. He uses an X-Acto knife to make deep cuts on his ankles. And he has never made an actual suicide attempt, but he does have spikes in suicidal ideation where he contemplates jumping off the roof of his building, and 2 times he has gone up to the roof and stood there and contemplated it and then changed his mind. He engages in frequent substance use, alcohol, and cocaine binges. He has impulsive aggression. He gets into verbal altercations pretty frequently, in the subway in particular, and sometimes even physical confrontations. And he has a history of childhood abuse, physical abuse by his mother. And he's been to the ER twice for suicidality, and he has been engaged in 3 years of outpatient therapy. I do want to say that I'm talking about ongoing treatment with somebody who's engaging in treatment, and that's a small population. It's not a small, but it's only part of the population that we're trying to reach with suicide prevention, but it's also a very high-risk group. Paul meets that, when you saw the 4 profiles of the suicidal ideation from the EMA data, he meets the moderate variability profile. His ideation and urges to self-harm are pretty chronic and variable and fluctuating. So let's apply the model to him. Step 1, we assess with direct inquiry. I'm not going to talk about this for too long, just to say ask directly and try to do it without anxiety. Very difficult. We want to find the sweet spot between being serious about a person's experience but not overreacting to it. And I think that we want to use our clinical skills as psychologists, social workers, psychiatrists. We want to really not just try to solve the problem. We want to step back and listen and hear the person's story so that we're not just trying to fix it right away, but we're trying to understand the pain that leads somebody to consider this as an option. And that's a very important part of asking, is also listening and not reacting right away. Very difficult when we're anxious ourselves and feeling that it's our responsibility to do something. The other thing is that people are afraid of disclosing how suicidal they are because they're afraid they're going to be hospitalized. So having that kind of listening and asking directly and try to reassure the patient that you are actually not interested in hospitalizing them. You're interested in understanding their pain and helping them with that and helping them manage it. And sometimes that can go a long way to encouraging disclosure. We don't want to assume that if people are not talking about suicide, that means that they're not suicidal. There was a graphic on one. I couldn't understand a lot of the Hebrew, so I was watching the pictures, and one of the graphics was the suicidal thought in the head, and I'm fine coming out of the mouth. If you don't ask, patients will think you don't care and you don't want to hear about it. And I actually reviewed a paper where that's really true, that clinicians do not want to hear about it, and the patients felt like their clinicians didn't want to hear about it. It may seem obvious, but then we did a survey in New York State, and we found that a significant proportion of clinicians reported discomfort about asking about suicide, and 12% said they would absolutely not bring it up, even if the record said that the person was at risk. So we need to learn how to ask, how to listen, and to have a sense of knowing what to do once we hear the answer. I talked about other risk factors for suicide. How much time do I have? 15? Okay. Other factors for suicide besides suicidal behaviors. So these, I'm not going to go through it. It's like a laundry list. You can look at this on this presentation on the website. But these are different factors to consider. And of course, access to means is one of the most immediate factors. And also protective factors. Don't forget those when we're all focused on risk factors, but we also want to weigh in with protective factors. So here's Paul's general risk and protective factor profile. He doesn't have a history of an actual suicide attempt, but he does have a history of what we call aborted attempts. I think you might be familiar with the Columbia Suicide Severity Rating Scale and the different definitions of suicidal behavior. And his acts of going to the rooftop and contemplating are approximating an actual suicide attempt and are very much a risk factor. He has a high-risk demographic, white male entering middle age. He has diagnoses that make him more at risk, recurrent major depression and borderline personality disorder. He uses substances. He has impulsive aggression and a child abuse history. And he has access to a number of means. He has X-Acto knives. He has his rooftop. He also has a lot of extra pills lying around. And now that's not part of his plan, but it's good to know anyway to really do a comprehensive assessment of what's lying around the person's house that they could use in a moment when they're at that peak of their ideation. And as I said, he has protective factors. He's a very likable young man, very talented. And when he's not in those aggressive, impulsive, stormy moods of his, he's very likable. He has some reasons for living, relationship with his father and brothers. Those are general factors, but more specific to Paul, what are the kinds of things that we can anticipate a spike in his ideation? Coming to a deadline on an artistic project, right? We know that from his college history. He feels very inadequate and a lot of shame about not being good enough and having to submit a project and expose himself. And any other interpersonal interaction that triggers feelings of shame and inadequacy and self-hate. So those are things for the clinician to know and for him to know in order to make those spikes in his ideation more predictable. Depressed mood in and of itself is not such a risk factor for Paul. In fact, it's the other way around. Rather than being more vulnerable when he's depressed, he's more vulnerable to depression when he's triggered. Okay, so that's his profile. Okay, so we've assessed Paul. Now how do we intervene? His treatment should maintain a continuous focus on safety all the time. And in DBT, if you're familiar with that, we use a diary card where the patient fills out on a daily basis whether they have suicidal urges or ideation, and every week brings that diary card in to the therapist, and the therapist asks explicitly what's going on this week with the suicidal thoughts. We can also develop a safety plan, a collaborative plan with Paul about how to stay safe and ride out those urges, and we can teach him coping skills. So I hope you're familiar with the safety plan. This piece of paper is also on the internet, on the safety planning website, and it gives you a place to write out the different 6 steps of a safety plan, but doing a safety plan is not just a matter of filling out the form. You need to use clinical skills. And we've been training people across New York State how to do safety plans, and because it seems so straightforward and kind of easy to do and very intuitive, people are not actually doing it the right way. So I just want to share with you, when you're doing a safety plan, if you know what to do, you want to be very collaborative. You don't want to fill it out and say to the patient, okay, you can try this coping skill and you can call this person if you need to. It's really a matter of establishing rapport and getting the patient to reveal what they think they can do and what their warning signs are. So the idea is to have this plan that's done together, much more likely for the person to actually use it if they actually were the ones to create it. I think the problem is people go home with a safety plan and then they never use it again. So that's the other thing, is when you're doing a safety plan with someone, you want to talk to them about, imagine what it would be like to use it, okay? Imagine the next time, Paul, that you have a project due at work and you start to feel suicidal. What's going to get you to think about your safety plan and to take it out and try to follow it? So the safety plan is based on those data of suicidal urges fluctuating and waxing and waning. And so this plan helps to anticipate when the spike will come and what to do when it does. And it's really good to be used if you're just seeing somebody once in an emergency room. It's like going to the emergency room with a broken leg and getting a cast. It's something that you can give them in the emergency room right there, a plan for them to take home with them. Or it can be used in ongoing treatments. And it can be done in 30 to 45 minutes. And as I said, it should be collaborative. And it incorporates evidence-based risk reduction strategies such as means restriction and skills enhancement. And also learning how to ask for help from social supports. So access to means is such an important intervention that I want to just spend another minute on it. In the United States, firearms is the most common method for dying by suicide, except in New York State, because we have actually better gun control laws than most of the rest of the country. And I checked for Israel, and does anybody have an idea what the most common method is? Okay, sorry, I guess I asked that question, but I really can't hear the answer. So it is hanging or asphyxiation. That's the same in New York State. I know that Israel's made great gains in terms of the army and with having less access to guns over the weekend, and it's still vital, you know, to reduce access to firearms. But we also have to keep in mind these other methods, and pills, ingestible poisons, sharps, and high places such as rooftops, bridges, or train tracks. And you're going to ask me, how do you reduce access to means to those kinds of means? And I'll give you some ideas. I just also want to share with you some data from a study of safety planning with veterans in the United States. And the first step of safety planning to figure out, or the second step is what coping skills you're going to use. These are the kinds of coping skills that they reported using, and all of them are in the category of keeping busy, right? Watching TV, reading, listening to music, the internet, video games. Again, the distraction is the best bet in the crisis. And here's using technology for the safety plan, the app, so that when you're coming up with the plan, you don't have to use the piece of paper, and the person can have access to it right on their smartphone. So Paul's safety plan, his warning signs were when he started to realize that he wanted to isolate and not be around people, feelings of self-hate and intense shame, and urges to use cocaine. So that's really important for patients to know, when am I starting to get at risk? What are the things that are happening right now, to get some insight and self-awareness as to when they need more help in staying safe. And they need to come up with those. So you can ask them, but don't give them the answer. And his coping skills were to play video games and take a bike ride. And the next step is to reach out for companionship. This is not to ask for help. This is just to be around other people and to not isolate. And he chose his roommate, his school friends, and going on online chat rooms as a way to not feel alone when he was feeling this way. You can see a safety plan is incremental. We start with the person trying to handle things on their own, and then getting successively more towards asking for help from other people. And so the fourth step, who would he reach out for actual help dealing with his suicidal urges? His father, his brother, and his roommate. And if that still wasn't working, then the next step is to contact his therapist or psychiatrist, his crisis hotline, or the emergency room. And his plan for means restriction was to cleanse the environment of the X-Acto knives, so he handed them in to his therapist. And working with the psychiatrist to limit the amount of medication he's prescribed at any one time. He also had a lot of pills lying around from past medication trials. He brought them in to his therapist. Now, this is a very cooperative case. You know, obviously it's not always so easy. He deleted the number of his drug dealer from his phone. And his plan for when the urges to go up to the rooftop was to have a plan to go the opposite direction, basically. If he's in his apartment and he's thinking about going up to the rooftop, he and his therapist came up with a plan to get out of his apartment, to go take a walk to the park or to a local cafe. So, yes, you can't remove the rooftop, but you can remove Paul from the rooftop. So that was the idea. And then the final step in the AIM model is step 6 to, as I talked about, be more flexible about treatment frame and, when necessary, increase your contact with a suicidal individual between session contact, phone or email. I discourage email and text. Some people are very comfortable with it. I cannot feel comfortable texting with someone who I think is at risk and feel like I know how they're responding to my texts. So I say, you can text me to reach out, but then we have to talk on the phone. You can encourage your patients to check in with you, give them more agency to take the step towards you so you're not doing all the work and not getting burnt out as much. As a DBT therapist, I have paging hours where people are free to call me for coaching on how to use their safety plan and how to stay safe. But I have a limit on my coaching hours, and by 9 o'clock in the evening, I'm not really of use to anyone for the most part. When I've had a session with somebody who's on the top of their spike in ideation, I extend my hours. I leave my coaching line on for the whole night. I have never had anybody call me in the night because just knowing I was there was enough. We had a plan for them to call me the next day. I'm just saying that you're thinking outside of the box, and I got that from my DBT training, that you can help somebody ride through an urge, and then it subsides, and then they can keep going on with life and not have a big disruption. Okay, so that's the idea. Okay, and you want to know the high-risk periods. Again, you want to know your particular patient very well, but there are also some general risk times that you should know about, which you probably do. Discharging from inpatient hospitalization, very high risk period. That's where the system needs to kick in to have more of continuity of care between transitions in one care to another, because those are some of the most high-risk times. If somebody goes to the emergency room but they're not admitted to the hospital, that's a high-risk time. And any transfer from one level of treatment to another. And the other thing I didn't learn in my psychodynamic training was how to reach out to family and friends. You know, again, the frame of psychodynamic informed psychotherapy is it's between you and the patient and confidentiality. And that's also a limiting factor when you're dealing with people at high risk for suicide. So the idea is to learn how to, you want to ask permission to get the contact information of family and friends, people in the natural social support environment. Sometimes I do it without permission, okay? When you're first treating someone, even if you don't know if they're high risk, you always want to get an emergency contact and their information. And you also want to start encouraging to involve friends and family in treatment planning and means restriction and safety planning. So Paul had his father as somebody who was very much a support in his treatment. Father came to therapy sessions when he was in town. He was made aware of the safety plan. He would check in with Paul regularly. He checked whether he was using his safety plan. and he would contact the therapist when concerned. Well, that's a big relief to the therapist to have somebody else in the person's natural environment helping. Okay, I'm almost done. And Paul lived with his father at one point for support. Contacting your peer clinicians, very important. That's another thing that's not necessarily, it's built into psychodynamic psychotherapy to have supervision, yes, but not a really supportive network, a team of people who know about your suicidal patient and can help you with ongoing support, even covering for you like they're doing for me now when I'm here. When in doubt, always seek consultation and have the contact information of the other providers and take a team approach. And finally, all of these steps then can be documented very clearly. You can really dot your I's and cross your T's and know you're following best practice evidence-based care for your suicidal patient by documenting all the steps that I've just reviewed before. And so the summary is in dealing with the main clinical challenge of fluctuating suicidal risk and ideation, we have these 10 evidence-based points that you can use right now to fill that clinical gap in your training. I want to thank my research collaborators at the New York State Psychiatric Institute in Columbia and the suicide prevention team working in New York State with Zero Suicide. Thank you so much.
Thank you very much. We have time for 2 questions.
Okay. I was wondering, this description, it sounded like a never-lasting story. How long do you keep the patient? What is your expectation that those bouts are going to end and you won't have to follow up?
Okay, great. The question was, how long do you do this with somebody? You know, is it an ongoing story forever? Hopefully, by doing the safety plan and teaching the coping skills, they are learning over time how to do this themselves. That's the whole point. It's collaborative, and they are sharing the responsibility to keep themselves safe. And the idea is over time to wean them from the need for as much instruction and support. Otto Kernberg, yes. Mm-hmm. Yes. I wish I would have been here, and even if I were here, I wouldn't have understood it. To hear Dr. Salzman saying that, and I'd be happy to hear. You're talking about depression. So, okay, he was saying in treating depression, but not suicidal behavior, right? So that's one difference. The other is, I think the research that we know about psychotherapy in general is that the type of psychotherapy usually doesn't matter, but it's the rapport between the patient and the therapist that's the only factor that is significant in whether a treatment is successful. And that kind of research doesn't have suicidal behavior as the outcome, it's other outcomes. So that's one of the points of my talk here, is that in the past, treatment hasn't been directed directly towards suicide prevention, and so the evidence-based treatments now that are being developed are different in that way by targeting directly, and that's why I want to share with you some of those aspects that you can be thinking about using. Yeah, okay. Okay, the question is when to include the family. And I would say you know, it's very variable because you don't always get cooperation from the patient about involving the family. So if someone's in the emergency room and you feel uncomfortable discharging them unless they have a supportive family environment, that would be a great time to try to involve the family if it's possible. And as far as individual ongoing psychotherapy, I know that now Otto Kernberg's and Frank Yeoman's treatment, transference-focused psychotherapy, is a psychodynamic therapy that was modified to treat borderline personality disorder and suicidal behavior. And they even recommend at the beginning stages of a therapy to have family members and support members be a part of the team from the beginning in order to have a safety net. So there's no reason to wait when you know somebody's at risk if they have people in their lives to involve them. You know, you have to be careful. Sometimes the family is more of a trigger than anything else. So, right.
Okay, well, thank you very much for a wonderful speech.
Okay.